Welcome back to the channel. Today we're diving into an open splenectomy procedure, including some anatomy, procedure steps, and anticipation tips. First, I'd like to introduce myself. I'm a CST and a surgical tech instructor. I also just completed writing a book called The Surgical Technologist Guide to Procedure Steps and Anticipation Tips. This book is available on Amazon. The link will be in the description. This book includes 207 procedures with steps, instrument suggestions, and suggested Mayo stand setups, and anticipation tips. In addition, I developed surgicaltechreview.com to help tech students throughout their program and exam. I'll put the link to that site in the description also. Now, let's get it started with today's video on an open splenectomy. Before discussing splenectomy, it's important to review anatomical terminology. Body planes such as transverse, sagittal, and coronal help describe incision orientation and imaging views. Directional terms like anterior, posterior, superior, and inferior are used throughout surgery to communicate positioning and anatomy clearly. These terms are essential for teamwork and patient safety in the OR. The abdominal is divided into 4 quadrants to help localize organs and pathology. The spleen is located in the left upper quadrant, along with the stomach, pancreas, left kidney, and splenic flexure of the colon. Understanding this helps anticipate exposure challenges and nearby structures at risk during splenectomy. The spleen lies primarily in the left hypochondriac region within the abdominal cavity. Reviewing body cavities helps distinguish between thoracic and abdominal structures and reinforces the relationship between the spleen and the diaphragm, which is important during dissection. The body cavities protect internal organs. The dorsal cavity includes the cranial and spinal cavities, while the ventral cavity houses organs of the thoracic and abdominopelvic regions. Inside the thoracic cavity, you'll find the right and left pleural cavities and the pericardial cavity surrounding the heart. The abdominal pelvic cavity contains organs of digestion, reproduction, and elimination. General surgery involves multiple abdominal organs, many of which are encountered during splenectomy. Structures such as the stomach, pancreas, colon, and liver are closely associated with the spleen, so the surgical technologist must anticipate protection and retraction of these organs throughout the procedure. Open splenectomy requires a major abdominal set, often supplemented with a minor set and large retractors such as the Balfour or Bookwalter. Because the spleen is highly vascular, having vascular clamps, clips, and suction readily available is critical for hemorrhage control. Splenectomy can be performed laparoscopically, open, or robotic. However, open splenectomy is preferred in cases of trauma, massive splenomegaly, or uncontrolled bleeding. The open approach provides faster access and better visualization in emergency situations. Common incisions include the midline, paramedian, Phanestoel, McBurney's, and more. Each incision provides access to specific organs while balancing exposure with healing and cosmetic outcomes. Open splenectomy is a surgical removal of the spleen through an abdominal incision. Indications include traumatic rupture, hematologic disorders, hyposplenism, splenic tumors or abscesses, and portal hypertension. The approach may be midline or left subcostal depending on patient condition. The patient is positioned supine, often with a slight reverse Trendelenburg and right tilt to improve exposure of the upper left quadrant. Skin prep includes the entire abdomen and left upper quadrant. General anesthesia is required, and blood products must be available due to the risk of hemorrhage. The spleen is a highly vascular organ protected by ribs 9 through 11. It lies beneath the diaphragm and is closely associated with the stomach, pancreas, and colon. The splenic artery and vein must be clearly identified and controlled to prevent bleeding. The surgical technologist plays a critical role in an open splenectomy. The incision is typically a midline abdominal or left subcostal incision. The Mayo stand should include a number 10 blade, Metzenbaum and Mayo scissors, DeBakey forceps, right angle clamps, long retractors, needle driver, and vascular clips or ties. Step 1. Incision and exposure. After the incision, exposure deepens quickly in the left upper quadrant. Long retractors and suction should be ready early due to the depth and vascularity of the area. Step 2. Enter peritoneum and pack abdomen. Once the peritoneum is opened, fluid may be released. Moist laparotomy sponges are used to pack and protect surrounding organs while isolating the spleen. Step 3. The costal margin is retracted upward. Instruments: Bovie, Metzenbaum's DeBakey's malleable retractor. Anticipate gentle traction to prevent injury. Step 4. Divide the splenocollac ligament. You'll use a Bovie or energy device, DeBakey's, and suction. This ligament may contain small vessels. Keep suction close and the field dry. Step 5. Divide splenorenal and splenophrenic ligaments located at the apex of the spleen. You're going to need Metzenbaum's, Bovie, or harmonic device and long retractors. Maintain steady retraction. Be mindful of the diaphragm and tail of the pancreas during dissection. Step 6. Identify and control short gastric vessels. Located towards the midline of the body near the hilum of the spleen. You're going to need right angle clamps, clips, or silk ties, and Metzenbaum's. Anticipate short gastrics bleeding as they bleed easily. Preload ties and anticipate clamp, tie, cut rhythm. Step 7. Identify splenic artery and vein. Splenic artery and vein run horizontal towards the midline of the body connected to the aorta and the portal vein. Instruments needed: DeBakey forceps, right angle clamp, and suction. Anticipate clear visualization, which is critical. Maintain gentle handling to avoid avulsion of vessels. Step 8. Ligate and divide splenic vessels. Instruments include right angle clamps, vascular clips or ties, scissors, or vascular stapler if used. Anticipation: confirm complete control before division. Be ready to manage brisk bleeding if vessel retracts. Step 9. Remove spleen from the operative field. The spleen is removed carefully to prevent capsular rupture and placed in a specimen basin. Handle spleen gently to avoid capsular rupture. Prepare specimen basin early. Step 10. Spleen removal and inspection. After the spleen is removed carefully to prevent capsular rupture, the splenic bed and tail of the pancreas are inspected closely for bleeding or injury. For instruments, you'll need suction irrigation, DeBakey's, hemostatic agents. Anticipation: the surgeon will look specifically for bleeding and pancreatic injury. Anticipate additional clips or sutures if oozing persists. Step 11. Irrigate and place drain if indicated. The surgical site is irrigated and a drain must be placed if indicated. Closure proceeds in layers, and counts should be confirmed early to ensure patient safety. Instruments include irrigation system, pull suction, JP or Blake drain, scissors, and sutures. Anticipation includes prime drain early and position near splenic bed if used. Confirm surgeon's preference. Step 12. Close abdominal wall and skin. Closure proceeds in layers, and counts should be confirmed early to ensure patient safety. Instruments are needle driver, facial sutures, Mayo scissors, skin closure supplies. Anticipation: begin closing counts early. Ensure drains are secured before final skin closure. Thanks for joining us today. Don't forget to check out our book, The Surgical Technologist Guide on Procedure Steps and Anticipation Tips, with the link in the description, and also our website, surgicaltechreview.com, for all your surgical technologist review throughout your program, for your exam, or maybe just a refresher. Thanks again. Like and subscribe.